Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association EHA. This is a special Lighting the Flame edition where we talk to some of our promising and active members in the hematology community. Our guests in this podcast series have volunteered their time to attend and facilitate the Lighting the Flame program where they mentor young trainees and medical students in their field of hematology. In this podcast series, they talk about their experiences in their field and give advice to those who are interested in becoming a hematologist. So sit back and enjoy the podcast. Disclaimer: this interview was recorded outdoors during the Lighting the Flame workshop in Romania, in a wonderful location next to the fields and forest. Therefore, you may hear some cricket noises in the background.
So welcome to this Lighting the Flame session where we're going to talk about how we communicate with our patients and caregivers, and also a little bit about how we take care of ourselves as doctors. And to start with myself, I'm Kirsten Grønbæk. I'm a professor of hematology at Rigshospitalet in Copenhagen, Denmark, working mainly with MDS. And please.
I'm Dr. Umut Yilmaz from Istanbul, Turkey. I work at the Istanbul University-Cerrahpaşa Faculty of Medicine. I'm an internal medicine and hematology specialist, and I'm studying as a clinical researcher in lymphoma in the last 6 months to a year.
I'm Mirjam Belderbos. I'm a pediatric hemato-oncologist in the Princess Máxima Center in Utrecht and also a research group leader there.
So my name is Konstanze Döhner. I'm a hematologist working at the University-Hospital in Ulm, Germany, and my major focus is clinical as well as research on myeloid diseases.
So thank you very much. I think to start out with this, I would like to hear a little bit how you manage to listen to your patients, what they come with, and at the same time balance how you then will guide them. Do you see any challenges in this? How do you manage such a conversation?
So maybe I start. So we had two really very fruitful and constructive workshops right now on the topic how to communicate with your patients. And it was interesting to hear that this is, I think, a very, very important point, listening to your patients. And I think the challenge here is to guide the patients when you talk to them and you offer them to start with the conversation and what is the problem, what is the issue. The challenge is to guide them a little bit through that you get the information you need, but don't interrupt them. And I think this gives them also a kind of feeling that they are respected by you, that you take them for serious, that they are in good hands. So the challenge, I think, for the students was, and for the young residents, how to find this balance that people are not starting to talk about everything and waving out into space, and you get lost as a doctor, and we are always under time pressure. But I think this is a very important point. Listen to your patient and be polite and take out the information and guide him or her.
And for me, summarizing is an important tool. So if a patient or parents in my case tend to get very elaborate, it sometimes helps to pull them back by summarizing what they've told me and say, okay, if I now understand what you've told me, and then I summarize it to basically explain to them or show to them that I've heard what they said, but also to narrow them down in their potentially extensive story.
That issue with the speaking with patients and communication was one of the things that I was most afraid of as a medical student. And I really had difficulty organizing it in my mind before starting as a physician. But after I started, I found it easy when I saw that when I cared for the patient and really cared for the patient, it just got very easy. And within a few months to maybe 1 or 2 years, it just became a regular part of my life to have good communication with patients.
And have none of you met this patient that sort of going in a completely wrong direction and want to talk about this very long time? And what do you then do? How do you get out of that situation?
In Turkey, our education level for the population is very diverse. We have lots of illiterate patients, and on the other hand, we have just as well as other countries, very educated and socioeconomically well patients. So we have to really adjust our behavior and the way we talk according to their level of understanding. And I agree with you about the summarizing. I always try to summarize at the end, and the length of the summary I try to arrange to the level that the patient can keep in their mind. I try to prioritize what's more essential for those who I experience forget most things, and try to expand that for patients and caregivers that can understand much better.
And of course, as a pediatrician, you're almost always confronted with at least two different levels of education, being the parents and the kids, right? Yeah. So depending on the age of the child, I usually try and engage them in the discussion and actually summarize the part for the parents and say, well, this is what I understand so far, but summarize it, and then I explain it in a child language to the kid.
Wow.
So that I simultaneously test whether I've understood what these parents wanted to tell me, but also engage the child in the discussion, which may have been too complicated for that.
Yeah.
And it's so also been.
I think another polite way to not really interrupt, but to guide it in the right direction is, as you said, I think just being polite and saying, oh, please allow me, did I get this right? And then ask a question that is coming out from all the information. Did you really have this diabetes since 5 years, or this might play a role here, or whatever? And then you can focus again back on the most important information without being impolite and say, okay, stop now. We are talking about your family since 10 minutes.
Yeah.
So I think you have to find a strategy to stop the conversation going in the wrong direction. And I think every one of us has its own strategy, and it's depending on the patient. Yeah.
Thank you. I think this was very, very comprehensive. What about, you have to inform some very concrete things, to talk very logically sometimes, and then also balance that towards emotions. How do you balance emotions and logical thinking when you communicate with your patients?
I think this is a very difficult issue, because I think there is no black and white, there is no left and right, there is no correct and wrong. Again, this is depending on your own personality, how much emotion you can deal with your patient, and it's depending on the patient. But I think what I have learned during my experiences in the communication with patients is that it's really helpful to have a kind of distance, and you have to define the distance for your own. But you have to find the kind of way of how you distance from your patients, and not getting too much involved in a deeper relationship to him, and don't take the problems of the patients home with you. You have to find a way, when you leave the door in the evening in the hospital, it's your life. Yeah, it's your life, and it's starting right now, and leave it behind you. And if there are issues, I think you have to talk to your colleagues, you have to self-reflect, or you have to get a feedback from your colleagues, but the distance is very important.
So, on the other hand, emotions can get in the way of people's ability to understand or hear what you're saying, right? Because if someone's obviously upset or scared or angry, or I don't know what emotion might be there, it can be useful to address that first. In order for them to be able to listen to the information that you're wanting to provide.
No, that's for sure. I think we should allow emotions from the patient side. It's for me more the question, how can I prevent myself to suffer with the patient because of the situation? Yeah. And I fully agree, you will get a lot of information out from these emotions, and maybe you can solve some issues at the very beginning of such a conversation. But for me, I've learned to protect myself a little bit with this distance.
Yeah. Can I ask, how did you do that as a young doctor? Because I think now maybe you're very experienced, right? But how did you cope with this in the beginning? Was it more difficult for you, and what is your advice to the young ones?
For me, if I was convinced that I did everything possible and I'd use the resources well, even though if I would feel the emotion, it wouldn't disrupt my judgment. But as Professor Döhner said, it's very personal. For me, it worked well. As long as I was convinced I was doing the right thing, I was equipped with the adequate knowledge, and I was using the right resources. Even the saddest emotion did not affect my judgment. I didn't feel it affected my judgment. But it's very personal. It could have, and I should have, and if it had, I would have found ways of managing it.
So what about the advice of talking to colleagues? I think when I was a young doctor, there used to be a nurse with me in the outpatients, so we were always two who had heard this visit, so I could discuss the situation. Do you discuss it with nurses, other colleagues? So how do you handle these situations?
Yeah, I usually discuss it. I'm thinking, I'm not sure if I've managed this skill yet. So I'm not sure if I'm the right person to ask advice to. But generally, I do find it helps to just having seen more patients.
Yes.
And just experience helps. And also talking to colleagues, involving them into these conversations, either bringing them into the conversation, if you foresee that it might be an emotional or heavy one, or reflecting on a conversation with colleagues.
Yeah, and I think we are talking about two different levels of emotions. I think if you are working as a pediatrician, I think the emotional distance is really hard to control. Yeah. And I think the learning process is much longer. And if you are a young woman, or maybe you have one or two children, I think it's even worse. It's really, really difficult to separate it from your own situation.
And personally, I even think that if I ever get to the level of not being sad when I have to tell a child that they have cancer, or that when I have to bring them bad news, that's when I should quit my job.
Yeah.
It's also a part of the job that you need to accept, and that's just intrinsically relating to this type of profession.
But for the young becoming hematologists, or for the young residents and students, I think it is a good advice to be patient with yourself. It's a learning process. You need some time. You need some situations to learn from. And I think it is really important to talk to your colleagues, to nurses, to people who understand the situation and are maybe more experienced, and give you good advice, or let you know this is not your fault, this is not your mistake, you did nothing wrong, and we can talk about it. I think that's very important.
Sounds really like good advices. Another thing that we're thinking a little about, you were a little bit talking about it, but how do you cope with patients with different social or cultural background? Do you have special ways of doing this, or special advices you can give?
I think it's very cultural. For example, lots of Turkish physicians want to go abroad to the United States, or where they can find better resources for research. But I always tell them, you can never be as good a physician in another culture as you can be here, because of that reason particularly. I can understand the cultural background, the expectations of a patient very easily in my own culture. I've grown up in Turkey, I've studied, I've always been there, and I've been a physician there all my career. It's very important to understand the culture, their expectations. And if you don't have that knowledge, I don't know how you could do it. And then I come from a region with really diverse cultural backgrounds.
So you know each of these different cultures, because there must be subcultures.
Yes, there are, but I think obviously I don't know all, but I know the main rules, and I got familiar with them, especially after a few years of being a physician.
Yeah. I guess you also have a multicultural society, right? So you must How do you cope with this? Yeah.
I think recognizing the fact that there are cultural differences is the most important thing, and that I might not that I'm bringing my own cultural background, and that might prevent me from fully understanding what this patient wants or needs. So actually actively asking feedback, trying to understand the fears and the question that a person might have, which might be completely different from what I would expect them to want to know. For me, that's one of the crucial parts of any patient conversation.
Yeah, I mean, this is another important issue, and I think we are a global, we have a global situation with lots of migration. I think we get used to more different social and cultural background, and I think it's as we said, it's really important to recognize or to have a kind of awareness. This is a patient having a different cultural and social background, and how far can I go to adapt myself to get into his situation, to understand him better. On the other hand, it's again a question of balance, because if you have to make a diagnosis, if you have to explain a therapy, if you have to manage the patient, then you also have to use your own cultural tools that you have, or you are not able to do something else because you are here in Turkey or in Germany or the Netherlands. But I think this is a very important aspect. And when I see my patient list in the morning and there are new patients, I'm always looking, is there an issue I have to address, because this person is coming from a different country and might have a problem also with language.
As I was thinking, could also be a big barrier. Yeah.
Can I just add a small point on the immigrants? You obviously have lots of immigrants in Turkey from Syria and Afghanistan. What I see is that immigrants lower their expectations to an incredibly low level. But if you want to see them at their own place, where they are, the expectations are completely different. For a patient residing in Turkey, but as you know, in Turkey there are very minorities, they expect to get the right treatment, their expectations are very high. But if they went to another country, the expectations would be very low. So you asked what their expectations were, and the patients were happy with that. In some cultures with us, it would not be acceptable for the patient. The patient thinks that the doctor should know.
Yeah, exactly.
My expectations. Yeah. I live here. Why am I not being understood by the physician that works here? There are some conflict in that issue, but I don't have that problem with immigrants. They know that there is a cultural difference, and they respect that I cannot understand their expectations very well.
But it's difficult, right? Because there might also be patients, and I've been in one of these situations where I was talking to a father who was not accepting a female doctor. And there you get into these complicated situations.
There are limits. Yes, there are limits.
Should I then have them transfer them to one of my male colleagues, or do you force them into your own cultural system? Those are very difficult.
It's the same with patients. You are not allowed. A female patient from Saudi Arabia coming with her sons, coming with her husband, not able to talk. You are not allowed to talk to her. You have to talk to her husband, and you are not allowed to examine her. Yeah, you are not allowed to be alone with her, or these men, these male patients do not accept you. Yeah. And I think there's also a huge difference depending on the culture with regard to compliance.
Okay.
Oh yeah.
Incredible.
But I also think, when you have, for example, the family to translate, you're never sure what was the message that were given on to the patient, and I find that very, very difficult to cope with, actually.
That's where language apps come in.
Yeah.
Because even if you tell the group of people in front of you that you have a language app, then I think the chances of them doing a false translation will be much, much, much lower.
But do you use translators normally in this situation, or?
It depends. Yeah. So for short communication, if there's, for example, we have a lot of Ukrainian patients in our institution. For short communications during morning rounds, we usually use apps like Say Hi or anyone translator apps, which actually work brilliantly. And then on a weekly basis, we have a live translator come into the hospital and actually help us communicate.
And the good thing is, with regard to migration, we do have nurses from everywhere. We have colleagues from everywhere. Yeah, and then you call your colleague, and I need a translator, which is really very helpful. Very helpful, because if you hire a professional translator, they often do not have the medical background.
No, exactly.
And I always have a bad feeling. I think, oh, what is this person now telling?
Yeah, exactly. That's
And if it's done by a colleague, it's totally different.
And what about social background? Does that mean anything in your country? I mean, do you have a public healthcare system, or how does it work?
So we do have a public healthcare system, which is, I think, very, very good in Germany. There is no issue with regard if I diagnose a patient A or a patient B with a different social background. The diagnosis is guiding me in my recommendation for the treatment. So I'm not really limited by healthcare issues, which is, I think, luxury, because it is not the case in every country, and this shouldn't be the case in no country.
But I think you told me you also had private patients. So what is that then?
The private patients, they have a kind of advantage that they will be seen by the head of the department or by the assistant professor, by the expert, but there is no difference in the way you treat them. They have to pay more. That's the big difference. And it's not always a privilege or an advantage if the head of the department is seeing you or a very experienced.
Because they have not seen patients for several years.
That could happen. That could happen. But it's the general service which is behind this German system and the private system. But important, no difference in the way you treat the patients.
I think the Netherlands is very similar to Germany, except we don't have this private system.
It's the same in Denmark. Yeah. We don't have the private system. What about you?
Completely similar to Germany.
Yeah.
Yeah, and I kind of say that going to the private care is like traveling with business class. You don't have to wait. It's more comfortable, but the plane goes to the same destination.
That's kind of nice. So they will get a private room, or what's the... But
yeah, it's more comfortable. They don't have to wait in line because their appointments are well set. And those are the advantages on private care. Yes,
absolutely. Yes, yeah.
They have single rooms sometimes. These are these little things. Maybe they have more options for lunch or dinner or selection, but at the end, the management and the treatment is the same.
Yeah. Okay. And then I think one thing we have not really touched about is how do you cope with losing a patient, and how do you communicate in the life with the patient?
First, maybe I can start again, because this was also a big issue that we had with the students and the young residents, and I think for them, this was the most important one and the most challenging one. How to tell a patient that he has really a worse diagnosis and that there is probably no therapeutic option for the patient, and different ways how patients deal with that.
Yeah.
This is also an issue that some people are completely neglecting or denying what happens. Some people react very controversial and strange. Oh, I'm happy that I know that, and I think this is something. This is depending on the situation, but what is clear and what we also said is, for us, it is very important to always be very transparent and to be honest with the patient, to tell him the truth, and to involve him and discuss with him what is possible, what kind of options do we have, and to offer to talk several times if it's not enough for the first time, to involve the family if it's needed. So this is the one side, and then we coming back to the emotional distance. I mean, we know that we are working in a field with diseases that cannot be cured in many, many cases, and we have to deal with the situation that we lose our patients. And as I said the days before, I think another really important aim for me is to provide quality of life for them, to be open to them, and to be a good doctor for them.
And so I think this is one of these situations that's also very much culturally dependent.
Yeah.
In the Netherlands, we are very direct when it comes to communication, and that also applies to these kinds of situations. So I'm generally very direct in explaining the prognosis of a patient, and if that means that that prognosis is poor, I need to be very explicit about that, so that I'm sure that they know. And to be really honest, I think most patients do know even before I tell them.
Yeah, I think
So
you're right. Yeah.
it's very rare for me to have this conversation and it being a complete surprise for the patient or their families. Usually, but these are often patients that have undergone multiple rounds of treatment in my center before we get to this conversation. And usually they kind of already feel that things are going downhill. And having that conversation might actually sometimes be a relief for them, because now we can actually actively talk about that and start making plans on how to still give proper care.
So what you're saying also, that this is sort of a gradual process.
Yeah, it is.
Or
Yes, of course, setting making a diagnosis, which has a poor prognosis, is a different conversation from telling, or in my case, is often a different conversation at a different time, as opposed to the conversation of telling the patient that they're actually going to die, or that there's no curative options anymore. And there's usually quite a long treatment period in between those two conversations, during which you really build up a relationship with that patient and their family, which also helps you have that final conversation, which is often not the final one.
Yes, I would like to say that establishing the patient and the physician trust during that treatment period makes that conversation possible.
Yeah.
Because if that trust hadn't been established, I wouldn't know how I would communicate such situation.
I fully agree, but it's interesting because where I come from, there's a big wish that we quite early on had this discussion. What are you going to do? I mean, how are you going to end your life? And I find that very complicated. I also like the process, but it's a balance, because also, you know, some patients also like to prepare a little bit for it, you know. So it's more how you tune your information, I guess.
Yeah, I mean, it's good to have such a process, but I do see a difference when you treat adult leukemia patients. You do not have the time, you don't have the process. They come into the hospital and then you have to tell them the diagnosis. And we are doing that in a positive way. We say, okay, this is a bad disease, but we have a lot of therapeutic options. We try to offer the best, what we have for you. And then you go in a very positive way. After 3-4 days, they have to think about it, they have to reflect, and then this positive spirit, we would like to do something, we would like to be proactive, we offer you are here in best hands. And then the patients start to accept the treatment, and it's very positive. But then, what happens when the patient is refractory? He went into the therapy with a total different expectation, and then it becomes sometimes really difficult to let him know that the therapy was not really successful, and we have to change the strategy a little bit. And this is the information also included. Your prognosis is not as good as we thought at the very beginning, and the optimism is not there anymore. These are really critical situations, and I think this means more than one conversation. This often means you see your patients, and every day you start again the same conversation and try to get this optimism again for a second line or whatever therapeutic option. So it's really very difficult. I think that there is no really clear rule how to manage that. It's depending on so many different issues.
Yeah. But still a clear conversation somehow, I thought. Yeah, absolutely. Yeah, absolutely. So, but this brings me to the last question, because how do you take care of yourself mentally, physically? I mean, in a busy working day and coming home with all this in your head? Good.
I swim. So I like to start my day early. I'm very lucky that the swimming pool in my hometown is located quite close to the hospital. And so I usually get up early. I go to the swimming pool. I dive in at 6:45, which is when they open. And that means I can swim until 7:30, 7:45. And if I get out of the pool around that time, I'm right in time for morning rounds, which start at 8. And then every Friday, there's 2 friends of mine joining me to the pool. And then after having done our morning swim, we allow ourselves a nice coffee in the coffee shop nearby, which means that I'm half an hour late and I often miss the morning rounds. But then realistically, nobody ever notices. So we'll have to go in with this.
It's a good one.
Yeah. Perhaps after having seen this video, they might start to notice.
That's right. Similarly, I also start the day early. My wife is also an infectious disease specialist, and she's a very busy physician, but she also enjoyed waking up early and doing some sort of physical activity. We usually play tennis, but also we run. But now we are raising a toddler, and we are actually at the survival mode.
Yeah.
So instead of taking care of myself, we usually take care of the toddler, which reflects on taking care of ourselves at this moment. But before having a child, it was very similar, keeping an active life, waking up early and getting good exercise and eating healthy diet.
So I can let you know how this looks when your daughter is 18 or 20. No, I mean I know all these things that you should do to care about yourself and how important this is. I must say I'm really bad in that, and I start my work in the morning and I really start working without having a really regular lunch time. I work until I have the feeling I'm almost done for this day, coming home very late in the evening. So maybe I have the luxury to have some coffee with some colleagues to talk a little bit, but then it's not very healthy to start your dinner at 8 o'clock in the evening or at 9 o'clock. So sometimes I do not really have time to do some physical things. I play tennis sometimes, but I'm getting older and my ankles are not so happy about that anymore. I started swimming. But what I would, from the mental side, what is really helpful for me is I have 3 kids and they are now more or less adult, and I really enjoy to do something with them. So when they come at the weekend, or sometimes they are there during the week and then going to concerts or whatever. And this is something from the mental side that is really helpful and keeps me young. Listen to their music, but I understand what they are doing. But it's absolutely right. I think we have to keep this little space for us where we do something like you are doing sports, and on a regular basis you are doing that. And I think this is something we should leave room for that. It's very, very important because it makes your mind free.
Yeah. And what about the weekends? Do you have the weekends only?
Not always. No. So there's weekend shifts. Yeah. But pediatric bone marrow transplant is a small team. We're seven transplanters. So that means that I have an evening or a night shift every week, basically. So then still with my colleagues, we sometimes just make sure that we back up for each other. So if my colleague wants to do yoga, I sometimes just take the phone calls during that 1 hour, and the other way around.
You should come to us, our colleague.
Sounds good, yeah.
Well, and I had a colleague who actually had one of these toddlers, and I live close to the hospital, and she actually had issues sometimes finding a babysitter. And then realistically, it's very rare for us to have to go into the hospital during the evening or in the night. So I was the one backing up in case that would happen so that she could just get home with her family. So I think as a team, being there for each other and sometimes doing very small things that can help out the colleague massively are important.
Very good, yeah.
Weekends are now mostly family time for us, but we try to find 3 to 4 hours of time to work. And other than that, we are just spending time with the family. And the weekends are happy.
Yeah, weekends are happy. That sounds nice. Yeah. I can tell I always used to work all the weekends, but then I figured out during COVID, I was just sitting in front of the computer all the time, so I'm giving myself a day off every week. And so it's usually Saturday or Sunday, depending on the weather, so I can go bike. With that, I think I will end this session, and now you know all about us, so thank you.
Thank you very much.